Why don't we get started? Good afternoon, everybody. Thanks for joining us for our implementation science series. Let's go to the next slide here. This is the agenda. We thought we would give about 5 minutes for people to check in. Those who are in person get some light refreshments. And I will do some introductory slides, after which we are going to have the usual talk. And then we'll have some extra time at the end for Q&A. So going back to the concept of implementation science, we spoke last time about the big chasm that exists between knowledge, the process of discovery per se, and how do we translate into clinical care? How do we apply that into action? Sometimes that journey in the, between the two banks is kind of tenuous or pretty brittle or pretty dangerous. We rely on the enthusiasm of the discoverer, of the person who made the discovery, to go forward. Sometimes we look backwards and we ignore the dangers of what lies ahead. Sometimes we rely on stakeholders and contexts and environments that are not as solid and not as well prepared. And sometimes we need to be adaptable to make sure that we have the right steps and the right aids in place to ensure success of that journey. As a recap, implementation science is really a science, a new discipline that is looking into the scientific methods that promote the generalizable knowledge getting into practice. How do we do the systematic uptake or scale up from research to evidence-based practices or interventions in the routine practice, with the final outcomes, the ultimate outcomes really to improve the quality and the effectiveness of our health services and care. There are other terms that are used interchangeably: dissemination and implementation. Some people say dissemination is part of the implementation science, knowledge translation, translation science. As we mentioned in the previous lectures, the implementation science draws from a number of contiguous disciplines, from public health to psychology to organizational theory, human factors engineering, quality control, operations management, and so forth. I thought I would go back to the important subway schematic for implementation science and kind of go back to when we have a specific question, when we are trying to identify a specific intervention or practice, and in this case it's called intervention or practice of interest. How do we assess the level of evidence and how do we apply that in clinical care? And invariably, the first note on this schematic, representation is assessing the level of evidence in terms of efficacy studies. Are there any particular efficacy studies? And I thought I would give an example, since we have a number of endocrinologists into the audience today. And I will give an example of using a biomarker. So let's say you're interested in studying a hormone, let's say melatonin. And you want to study in a specific human specimen. And let's say you wanted to study it in urine. And you want to use that as a methodology of maybe diagnosing a specific condition. So use it as a biomarker for diagnostic purposes or for severity stratification or even for therapy. And how do you go about this, right? Well, first of all, you need to devise the methodology, the assay that will actually make sure that you're measuring the melatonin in urine as you start that out. And you may discover that that is actually very, very low level. And maybe the pharmacokinetics will take you to the, well, maybe you need to look at metabolites of melatonin in urine and discover maybe that the sulfatoxy melatonin metabolite is the one that you should be measuring in urine. And then you go ahead again and develop the methodology and make sure that you're measuring exactly what you wanted to measure. And there is good precision of the methodology. And then you kind of study what's the intrinsic variability. How does that change from assay to assay? How does it change into one individual, so intra-individual variability? And maybe you go and start looking at different individuals. And maybe you are able to come up with a specific cutoff for that specific biomarker. Again, with the specific goal that you have for diagnosis, stratification, or for therapy. And then you go to the next level and ask, is this cutoff something that is of clinical utility? And how do you study that? And you go into this type of comparative effectiveness research. So you moved away from the efficacy stage into effectiveness, the studies at the point of care. And maybe you'll identify that patients who are on beta blockers don't have that type of level as you'd expect in those without. Maybe you'll discover the patient with diabetes have a different type of level. So that's the point where you in clinical care, you start coming up with a specific threshold and you know exactly how does that apply. Does it apply in everybody? Do you have any specific groups? And if you don't have the answers for pretty much everybody, you have to continue to do those type of studies to make sure that you are refining your population that you're studying and you have the right cutoffs. If you identify that this is all that we need to know, this is all we have to worry about, and then we excluded and included everybody, then maybe you just go down that pathway where you do implementation strategies, devise a specific plan, and how do you approach that in clinical care. And sometimes, as we mentioned in the past, you may need to do the comparative effectiveness implementation strategy kind of hybrid study, where you maybe you'll look at how do we identify the patients that we're interested in. Let's say you're interested in patients with insomnia. Should you screen everybody with this assay? Should you do a questionnaire first? If you do a questionnaire, which questionnaire, what cutoff you're going to use? And this may come in that category where you use a hybrid approach between effectiveness and implementation science. So I thought I would tease you enough. But I really wanted before the talk tonight is to present you with a framework that maybe you'll consider when you're listening tonight to the talk that we have chosen for you. So this is kind of a hybrid between implementation science and intervention mapping. So it's called implementation mapping. And a lot of us really live in this area of evidence. So we're trying to build up the evidence. We're trying to come up with specific threshold, to come up with specific algorithms. At what point this becomes an evidence-based or evidence-informed intervention is where I'm trying to take you now to kind of what do you do to assess what's going to be the successful implementation of that. And you may go and say, well, we need to devise a specific strategy. Maybe we have to include this in the guidelines. And then how do we incorporate the guidelines into clinical practice? And then you have to take into account the determinants of the implementation. Sometimes it's the context, sometimes the inner context, sometimes the outside context, sometimes it's the specific stakeholders that you have to involve. And then how do you assess the implementation? What are the performance objectives and specific aims? And then the ultimate goal, as I said, you really want to improve the healthcare and the quality of life of your subjects. And a lot of times when you're trying to come up with this type of journey, you have to walk backwards and say, we're going to start out with what's the final outcome that we're interested in. And then you go back and look at what's task one. And we want to assess the aims of the outcomes. Then what's task two? We want to see how do we approach the specific determinants or the context. And then you go back and then come up with that complex of implementation measures that will create your strategy to go forward. So hopefully that was not too theoretical, but today's talk, we're very, very honored to have Jay Findling, Professor of Medicine and Surgery, and Hershel Raff, who's also Professor of Medicine, Surgery, and Physiology, to share with you their own journey of discovery and then the implementation of their discovery, which was the use of salivary cortisol assays. But you'll hear it's not only about that, there are a few other discoveries that they will be touching on in their presentation. So Jay and Hershel is on Zoom, Jay's here in person. Welcome, and let me stop sharing this and start sharing your presentation. Share? No, perfect.
Well, thank you very much, Tavi, for that introduction. And
hey, Jay, put it in presentation mode. It's the bottom right. It shows a little projector at the bottom.
It is
No, it's not in
Yeah, so
presentation. It's what
let's
I do
go
for a
to-
living. It's the bottom right, next to the slide bar.
No, it's in presentation mode in the room, so we're trying to figure out why.
Oh, don't worry about it then. Okay, as long as they can see it in the room. We
Well,
can
if we
see it.
advance in the room, you might not be able to see it.
That's right.
Okay.
All right,
Um,
we'll start, see what happens. Well, again, thanks, Tabby. And this is a story about how a kid from who grew up on a farm in East Central Indiana met a kid from New
Jay,
York
we
City.
can, we can't see your slides. We're still in Tabby slides.
This way. Screen one. Here. And we'll take this one. We'll make this into hidden.
Nope.
Of course.
This may be the last slide of my
Here,
presentation,
okay.
folks.
No, you're still in Tabby slides. I can come down there and show you how to do it if you want.
No, we just can't get the Zoom bar out of the way
Right.
because it's keeping us from.
Should be able to just pick it up and move it. There we
Work
go.
now?
Yeah.
All right,
There we go.
that's what we were working on. Okay.
Advance the slide. I think you might
Yeah,
still be in
advance it
Tabby.
also, make sure we're still not in that. make sure-
No, you were still in Tabbies.
Yeah, so let's get out of
Oh.
it and share the other
You
one.
might have
I
to
think
close
sharing-
PowerPoint. and
Instead of
reopen.
sharing the screen, share the presentation. What it's doing, it's completely
Everybody
sharing
would
what
just
you
come
have.
in here, they'd have food, they'd be sitting here. we'd be
So
going-
if we share it again,
So go to share thing.
Sometimes you have to close
Don't do
PowerPoint and
screen.
reopen it.
Don't- Yeah.
Nope.
Stop sharing. Go to share. There. This is the presentation, right?
I can show it
that
from
was
my,
mine.
why don't
That
I
was
show it
mine.
from my computer? Let's see if that works.
So where's the presentation?
it's this one.
Go to Zoom. Share.
Can show it.
Hershel, do you want to just share yours?
I think you see it now, right?
That's the one.
Yep.
right?
Yeah, we can see it. Oh, there we go. Now we got it.
You got it full screen?
Yeah.
Sorry about that.
You see it, Herschel?
Yeah.
Okay, thank you. Again, I'll just start over. This is a story about how a kid who grew up on a farm in East Central Indiana met a kid from New York City about 40 years ago, over 40 years ago, in San Francisco. And kind of describes our journey over these 4 decades and how we disrupted the diagnosis and differential diagnosis of arguably the most challenging diagnostic problem in clinical endocrinology, and that's Cushing's syndrome. Just to give a background for those of you that are not endocrinologists, the syndrome described by Dr. Cushing in early part of the 20th century really has couple different subtypes. One, of course, is ACTH secreting tumors, usually in the pituitary, and that's what Dr. Cushing describes. So that's called Cushing's disease. And non-pituitary tumors can also make ACTH. That really wasn't discovered until the mid to late 60s. These tumors are often not radiologically present. And now that we have more sophisticated pituitary imaging than we did back in the 70s, when we didn't have any, we found out that they're often still unremarkable in Cushing's disease because the tumors are so small. And many patients who don't have Cushing's disease at all have small incidental pituitary microadenomas. And after Dr. Cushing's description in the 1930s, it became clear that adrenal tumors, benign and malignant, could make cortisol autonomously without ACTH. So it's called ACTH independent hypercortisolism and cause a syndrome similar to the one that Dr. Cushing described in his monograph in 1932. So we're going to really start not with the diagnosis of Cushing's syndrome, we're going to end up with that, but the first diagnostic dilemma was the differential diagnosis of ACTH-dependent Cushing's syndrome. And this whole story really evolves around gaining some degree of reputation and authenticity of our group that so that other people in the scientific and clinical community could acknowledge and actually believe what we had to say. I was fortunate to be at UCSF with Blake Terrell, who was my mentor, clinical endocrinologist, Charlie Wilson, who was arguably probably one of the best pituitary neurosurgeons of the 20th century, and Mary Dahlman, who was Hershel's, with whom Hershel did his postdoc, who was very interested in the hypothalamic pituitary adrenal axis. And what was not known, I mean, you have to put things in perspective. I mean, we had pituitary Cushing's, we had adrenal Cushing's, ectopic Cushing's. How do you make that differential diagnosis? Well, there was no imaging in when I got to, there was no imaging of the pituitary. So they were operating on pituitaries without any imaging. So they had to be sure it wasn't ectopic. And we figured out that if you do something called inferior petrosal sinus sampling for this differential diagnosis, which we published in 1981, and we described 10 patients, 5 of 6 patients with pituitary adenomas whose IPS could be catheterized had a ratio greater than 2 from the petrosal sinus sampling where venous effluent comes from the pituitary compared to central or peripheral gradients. Ectopic patients did not have a gradient. And we found that the jugular venous sampling was not diagnostic. And the ACTH measurements were done with Mary Dahlman's RA, and that's where Hershel was, and that's how I met him. So this was published again in 1981. We started the work in obviously 1979. And just to give you how controversial this was, when I presented this, I applied to a job at the University of Connecticut. Don't ask me why I applied there, and they wanted me to give a presentation. I presented this data and I was just booed. I mean, I was chastised out of the room. They didn't hire me. Fortunately, they did take me to dinner. They did promise to do that. And they didn't even pay for my expenses to go there. They refused to pay because they thought this was just ridiculous. We could do high dose dexamethasone suppression testing. We don't need to do this procedure. More about that in a few minutes. Now, when I started this project, it was interesting. In 1979, it was not easy to figure out what the venous drainage of the pituitary was. I mean, now of the pituitary or the brain for that matter. But when I finally went to the UCSF library and spent a few hours with the librarian, we finally found not this slide, but other more sophisticated slides. And jugular bulb is here, but you can see there's a lot of venous admixture in the jugular bulb. So it just didn't make any sense that jugular bulb sampling would be satisfactory to make this differential diagnosis. And that's when we found that the inferior petrosal sinus, in contrast, was a successful test for the differential diagnosis of ACTH-dependent Cushing's, and clearly differentiated pituitary from ectopic Cushing's. So then the story sort of moved to Milwaukee, and we set this procedure up, and by sometime in the 1980s, Hershel can remember, obviously CRH was discovered, and the NIH kindly gave us some ovine CRH, and we had an IND with the NIH to study this. And this is obviously Hershel set up the ACTH assay in our research lab, and we found that with CRH, it really magnified the gradient in the inferior petrosal sinus compared to the periphery. And also in some patients with pituitary Cushing's at the basal state, there was no gradient. And it wasn't until you administered CRH that you uncovered a pituitary to peripheral gradient consistent with Cushing's disease. So, and I don't know if Hershel wants to comment, he was very instrumental compared to ectopic, where of course there is no gradient either before or after CRH. But Hershel really did obviously all these ACTH assays. And Hershel in fact, he went to every one of these petrosals. He was there at every one of them. So he probably knows more about this than I do, to be honest with you. but this really established us as, I think, a center for the diagnosis and differential diagnosis of Cushing's. This was published in the same year, almost within the same month as the big NIH publication that was in the New England Journal of Medicine. We had submitted this to New England Journal. Of course, they didn't take it. I mean, we only had how many, 20 patients. And of course, the NIH had 230 patients. So I'm sure it makes any difference whether you have 20 or 230, but I guess the New England Journal liked the 230 more than the 20. And then by the early 2000s, people were reporting false negative testing with this procedure. This came from Brooke Swearingen and Beverly Biller and the group at the Massachusetts General Hospital. And we realized in retrospect that we had a couple patients that did not have a dominant IPS to peripheral ratio consistent with pituitary, but ended up having pituitary tumors. And then we, and Hershel can probably elaborate on this more than I can, we had saved all the plasma samples, all these peripheral petrosal sinus samplings that we'd done. He had them in his freezer. So we went back and started, and this was really Hershel's idea, not mine, to use prolactin as a kind of a surrogate of pituitary venous drainage. That is, if you're really in the petrosal sinus and you're really harvesting pituitary venous effluent, prolactin level should also be elevated. It's a very fairly high level prolactin level in the periphery, let alone the petrosal sinus, and we use that as a gradient. And then we constructed a sort of a, if you will, as a ratio between the peak ACTH and the basal prolactin. And we saw these index cases which had been false negative when you correct it for prolactin were consistent with pituitary Cushing's, and all these patients had successful pituitary surgery for Cushing's disease. So now the standard of care, I think, the standard should, at least we think the standard of care for doing this procedure is to measure prolactin to validate the integrity of the venous sampling. Much like we do in adrenal venous sampling, we use cortisol as a surrogate of adrenal venous effluent. For petrosal sinus effluent, we use prolactin, and it works, it's very reliable, works very well. Hershel, do you have any comments?
No, just for those, I guess you all went to medical school one way or the other. It's just the Fick principle. And I just picked the hormone that was the highest production rate. As Adriana, if she's there, can tell you 80% of the secretion of the pituitary is prolactin. And that's why I picked it. I figured if it's, if it's the major secretory product, it should be by the Fick principle, the biggest gradient. And it turned out to be the case.
Yeah.
So go study review Fick principle from your first week of medical school.
So this was published about, as you can see, 20 years ago. And I think, again, has been validated by others, not just by us. I mean, there are, it's like always, there's always arguments about what the ratio should be, but everybody agrees that this does validate the integrity of the sampling. So then to go back, I mean, this is really one of my pet peeves, but in the 70s, actually it started in the 60s, people were doing high dose dexamethasone suppression testing because they thought that, this is before imaging, got to remind you, no CTs, no MRIs, no dotates, no PETs, no nothing. You had to be you had to do a history and a physical. I mean, I know that's all outdated now, but that's what we had to do. That's all we had. And so people did high dose dexamethasone suppression testing to segregate people with pituitary from ectopic, because people with ectopic wouldn't suppress very much, and people with pituitary would, with higher doses of dexamethasone. Well, it's interesting that people came to that conclusion because this test was set up before anybody even knew ectopic ACTH existed. So it was just sort of, nobody even did a study. I mean, it's unbelievable how people believe this and nobody ever actually did any studies. It was incredible. So when we got to Milwaukee, we looked at our data and we looked at, these are 102 patients with Cushing's disease in whom we had and a bunch of ectopics, 17 ectopics. And there was overlap in urine cortisol. Now, patients with ectopic, tend to have higher levels of, urine cortisol than Cushing's disease patients or pituitary Cushing's, but there's a lot of overlap. And similarly, ACTH levels much higher in ectopic usually, but overlap. So then we did high dose dexamethasone depression testing, 15 with ectopic, and I can't read that number. I think it's 66 with Cushing's disease. And here's the data. Now, if you can tell a difference between this group and that group, you're a lot smarter than I am. But people would use 50% thresholds, 30% suppression thresholds, all sorts of thresholds. And we said it's nonsense. I mean, you can't tell the difference between ectopic and Cushing's based on high dose dexamethasone suppression testing, sort of validating the whole need for petrosal sinus sampling, particularly in patients without pituitary imaging abnormalities. Now, obviously, by the late 80s, I don't know, no, actually the 90s, I think, pituitary imaging became available and it's gotten much more sophisticated. So the need for petrosal sinus sampling has waned a great deal because of more sophisticated pituitary imaging. But what's surprising about this is not only did this data kind of disrupt what people thought, it hasn't changed. This is still taught to medical students. It's still taught to medical students. In fact, Hershel can tell you, even in up to date, they still use it in up to date. Am I right, Hershel?
Yeah, despite protestations that they should take it out.
Yeah. I mean, it's almost beyond comprehension. So high dose dexamethasone depression test probably provides very little help in the differential diagnosis of Cushing's. So we thought we had conquered, but we really made some significant changes in how we approach the differential diagnosis of this disorder. But it was pretty clear that we needed better diagnostic testing than what we had, and we'll get to that in a minute. But and this is Dr. Hershel and I have both given the Gabrilov lecture at Mount Sinai within the last 5 or 6 years. And Dr. Gabrilov was one of the really foremost investigators and clinicians in the evaluation of people with adrenal disorders. And I had the privilege of meeting him and having him sign his famous book, The Human Adrenal Gland, which was published in the early 1960s. But in that book, I read this sentence, which I thought was almost predicted a lot about what we know about Cushing's syndrome now. He said, how can we detect the mildest forms of Cushing's syndrome by data obtained only from florid instances of the disease? Accordingly, the tests may fail when we are uncertain of the presence or absence of the disease. So I think it was forecasted the idea that, in the 60s and 70s and even into the 80s, the only people with Cushing's syndrome we were diagnosing looked like mini G, the index case. But now I think it's pretty clear we have patients who have much milder degrees of neoplastic hypercortisolism, which is what we call it, which is clinically significant, warrants investigation and treatment. So what has been sort of uncovered in the last couple, maybe 2 decades, certainly in this century, is that many studies have shown that somewhere between about 0.5 and 8% of patients with resistant hypertension have Cushing's syndrome. 0 to 3% of poorly controlled or newly diagnosed patients with type 2 diabetes. And there's a study now ongoing with 1,000 patients with type 2 diabetes to find out how many have Cushing's. That if you look at patients who have obesity, type 2 diabetes, hypertension, and polycystic ovary syndrome, those 4 things, if you have 2 of those 4 things, you have about a 7% chance of having Cushing's syndrome. I'm going to repeat this: obesity, diabetes, hypertension, and polycystic ovary syndrome. Think about that for a few minutes. That's internal medicine. So if you have any 2 of those 4 things, you have a 7% chance of having Cushing's syndrome. This slide, 6 to 9% of patients with incidental adrenal nodules, but it's probably actually even higher than that, may have mild cortisol excess. And about 11% of patients with osteoporosis and vertebral compression fractures. If you look at all patients with osteoporosis, it's about 3%. But interestingly, obesity is not enough. You have to have more than just obesity. Obesity alone, In this one study of 369 patients, none of them had Cushing's syndrome. So you have to be more than just obese. You have to have some metabolic dysfunction to warrant screening. So who should be screened? Well, this is, the obvious cases. Unfortunately, those are, well, fortunately, I guess, those are fairly rare. But there are milder cases. I mean, here's a woman with hypertension and new onset of type 2 diabetes. Certainly doesn't look very Cushingoid. So what other things may provoke screening? Well, we know patients who have myopathy, osteoporosis, the odds ratio goes up dramatically, and obviously patients with adrenal adenomas. Now, it's interesting that obesity itself actually decreases in most studies, the odds ratio. And that seems, well, that doesn't make any sense. Well, it makes a lot of sense because you're screening a lot of obese patients. Turns out that most of them really don't have Cushing's. So it's obesity alone is just not enough. You have to have some other either physical finding or metabolic dysfunction to warrant screening. So for a long time, it's been known that there are three fundamental physiologic disruptions in patients with pathologic hypercortisolism. And one of them is impaired circadian rhythm. That is, they have increased cortisol late at night and no diurnal rhythmicity. They lack suppression of cortisol after dexamethasone, the low-dose dexamethasone suppression test, which we'll talk about in a minute. And they measure increased urine cortisol. Of course, in the old days, we didn't have urine-free cortisol. We had 17-hydroxycorticosteroids. That doesn't exist anymore. And these tests are all complementary in terms of understanding the pathophysiology of this disorder. And the low-dose dexamethasone suppression test, which is widely used by endocrinologists and even non-endocrinologists in the diagnosis of Cushing's, was introduced back in the 60s. The two-day test has been, for all practical purposes, abandoned because it's cumbersome and required urine collections. The overnight test, which was, again, at UCSF by my mentor, Peter Forsham, was a milligram of dex at 2,300 hours. And the normal post-dex cortisol was considered less than 5. And this stood up for 2 or 3 decades. It's amazing how this 5, I won't get into how they came up with that number of 5. It's actually kind of funny because it's so ridiculous, but that was in the literature, and that was a religious statement. 5 micrograms per day. That was like so you can't even imagine where this number came from. You can't even imagine how, if you look at the hard data, and even the 1963, it's laughable. So when we got to Milwaukee, we started looking at our patients. And these are patients with proven pituitary Cushing's. And as you can see, of 73 patients, these are the post 1 milligram dexamethasone cortisol levels. Whoops, I'm sorry again. So as you can see, at least 7 of them had between 3 and 5. And there were several less than 2, about 6 less than 2. So there was 13 patients out of this number of 73 who had post dexamethasone cortisol less than 5. And this kind of blew things up. And I think people began to realize it, and now everybody embraces this, but I mean, at the time, it was pretty controversial. And finally, in Europe, I think, and in other places, they started using less than 2. Some people use less than 3. They kept moving this number around. Now, the consensus, worldwide consensus, is that it should be less than 1.8. So that's kind of where this stands now. But this was pretty controversial at the time. But I think it's now been, accepted that many patients with Cushing's disease have post-dexamethasone cortisol levels, certainly less than 5, and some even less than 2. So now we're going to segue kind of into how we got to salivary cortisol. So in the early 1990s, this is from John Neal Price, who just became elected president of the Endocrine Society and a superb clinician from Sheffield. He published this, he may have been a fellow when he did this, 150 patients with Cushing's syndrome from 1970 to 1994, and 110 had Cushing's disease, 12 ectopics, 8 occults, and 20 adrenals. compared it with some normal subjects and some patients with non-endocrine conditions, and found that all these 29 patients had midnight cortisol less than 50 nanomolar, that's 1.8 micrograms per deciliter. And that all patients with Cushing's had levels much greater than 50. In fact, the range was 70 to 2000 nanomolar. And that, like what we had found, low dose dexamethasone suppression tests missed some patients. Well, I can remember shortly after I read this, I said, well, this is interesting. And I remember going to the Wisconsin State Fair. Now, if you've ever been to the Wisconsin State Fair and you walk around, you think, boy, all these people have Cushing syndrome. I mean, this is, wow, this is unbelievable. Now, we can't put all these people in the hospital, put in indwelling catheter and study them at midnight to see what they're sort of, I said, that just doesn't make any sense at all. So and then another study, which came again from the NIH, looked at the same thing and showed unstressed midnight serum cortisol and showed the same thing, that patients who had Cushing syndrome tended to have much higher levels than patients with a condition which they call pseudo-Cushing syndrome. Now, I don't know what, we have never embraced this term pseudo-Cushing's. These, I guess, are people who have clinical Cushing's, may have high cortisol, but it's for some other reason, like alcohol, renal failure, severe major depression. And Hershel and I just recently came up with different terms for this, which we published in 2017, called endogenous Cushing's neoplastic hypercortisolism, and the pseudo-Cushing syndrome we characterize as non-neoplastic hypercortisolism. Now, much to our surprise, and maybe somewhat we're prideful of this, this has now been embraced worldwide, these terms. In fact, it was so well embraced that another paper, probably Hershel, at least a year later, published and plagiarized the whole concept. I mean, it was unbelievable. It was absolute plagiarism, because Hershel and I got to review both of them. And Hershel, you can tell him what you told the editor. This is hilarious.
So there's a thing called COPE, which I'm a member of. I can't remember what it stands for, but it's basically for publication misadventures, unethical behavior. And I told the editor if he dare publish this paper that I would report him to COPE, because not only did they plagiarize the concept, but they didn't even reference our paper, which was even more insulting. And I basically threatened the editor, and obviously he never published it. It was incredible. I never saw anything quite like.
So anyway, and Herschel's done some very nice work with non-neoplastic hypercortisolism in patients with end-stage renal disease. Not, we're going to mention that today, but Herschel's really done some of probably the best clinical research in that area. So these two studies and others, these aren't the only two. How could we get an unstressed midnight blood sample from a patient? Well, that's really impossible. So we realized that there's some other way patients at home could measure cortisol and get an accurate level. And that's when, and I'll let Hershel take over now. I think I addressed this with Hershel, and he said, "Oh, you can measure it in the saliva." And Hershel, go ahead and take over.
So saliva, in fact, you can measure all steroids in saliva, and they're quite good. Testosterone, estrogen, particularly 17-hydroxyprogesterone in babies with suspected congenital adrenal hyperplasia. But the only one that really is caught on so far is, you can measure aldosterone. That's caught on is salivary cortisol, because it's blindingly easy to measure and it's a very high concentration. So it took me a while to find out that the actual first paper on this was published in 1960, and there were a few smatterings of papers here and there, but it never caught on. And I don't want to embarrass Dr. Findling, but you need to have an entrepreneurial nature when you have an idea. And I think that speaks to this implementation science, because we didn't invent the assay. We just kind of built a better mousetrap, which is really, I guess, the point. So our original study, Jay said, hey, let's do it. I found, and I'll show you in the next couple of slides, a method that we could modify to use it. And we published this paper in 1998.
you want me to move to the next slide, Hershel? Did we lose Hershel? Hershel?
Yeah, I'm here. Yeah,
Okay.
move to the next slide.
All right.
So if you remember what the Papa Nicolau, the NIH study looked like, the salivary cortisol basically came out exactly the same. With a very high sensitivity and specificity. These are patients that were normal subjects. I mean, truly normal subjects. These are the patients that we refused to call pseudo Cushing's. So we just called it rule out because we didn't have the name non-neoplastic yet. And you can see, I mean, you don't need a lot of imagination to see. And then Ty Carroll, who is at MCW, was a fellow at the time, did a meta-analysis of all of the published data, which I'm going to show you in a little while, and basically confirmed this. There have been several other meta-analyses done since then. Next slide. And then when I gave this talk originally at the Pituitary Society meeting, all the clinicians started squirming and saying, oh, this is so hard. This is so hard. And this is so easy because it was published in clinical chemistry. You can do it in a dolphin, a rhinoceros, a chicken. And it's so easy that this guinea pig sampled his own saliva. They just hand him the Q-tip and he did it himself. So I said to a physician who I won't mention his name from the University of Michigan, if a guinea pig can do it, I think your patients can do it. We've done it in neonates. We've done it in patients with Alzheimer's disease. It's so blindingly simple. And maybe that's why people don't like to do it. It's too simple. I don't know. But it's really, really easy. And in fact, where it's mostly used is in quote unquote stress research. If you search salivary cortisol, there are literally thousands of papers on studying stress in humans. And I've seen papers, people in submarines, speaking of the disaster that happened, people at the top of Mount Everest. I saw one on Korean golfers, NASCAR drivers. I mean, it's so easy to do that you really have to go out of your way to screw it up. So Jay, why don't you take it back?
All right. So I think this, and then I want to acknowledge Vidya Kadambi, my boss, and she about 15, I think over maybe a little over 15 years ago, she was a fellow with us. And you know, one of the things I tell people, I mean, be nice to everybody because you never know when somebody's going to be your boss. So you never know. I've learned this in 40 years that many people who I trained or under me actually became my boss. I have a lot of interesting stories about that. But Vidya is, I mean, she's a terrific boss. When she was with us, she became interested in this concept of late night salivary cortisol. And at that time, we had seen several patients. Now you got to realize that in the 20th century, urine cortisol was considered the gold standard. I mean, if you had a normal urine cortisol, you did not have Cushing's syndrome. And we began to notice that there were a lot of patients. Here's 11 patients who had normal urine cortisols. These are all patients with proven Cushing's syndrome.
And that was 24-hour urine.
24-hour urine. And we found that although these patients, some of them had a few elevated urines, but many of them were normal, but that most of them had elevations of late night salivary cortisol. And so we began to realize that late night salivary cortisol was probably more sensitive than urine cortisol. And I think this was also in 2007, when this was published, was kind of controversial. Now it's well accepted, but it's interesting how we kind of made this observation just from in our clinic, and it turned out to be valid, and it's been validated by others, not just by us. So I think that was kind of the segue into, you know, so this we published, what year was it? 98, I guess we published. So in 2007, Lynette Neiman at the NIH was, and the Endocrine Society had decided they're going to have guidelines for the diagnosis of Cushing's syndrome. And Lynette, who I happened to be at the Endocrine Society with last week, now she was drunk when she said this, so please take that into consideration. She had been intoxicated when she said this. She's hugged me and said, you know, you and Hershel really disrupted this whole diagnosis of Cushing's syndrome. She said, I was so glad. I said, I put you on the committee to establish the guidelines. And she said, I really am happy that I did that. And so fortunately, and you gotta realize, even though this was 10 years after we published it, it still wasn't quite as embraced in all parts of the world as it is now. But nonetheless, when we established the guidelines, it did get in there as one of the preferred screening tests for patients with suspected hypercortisolism. And obviously, it did not obfuscate the use of dexamethasone suppression testing, or for that matter, urine cortisol. I think many people now would acknowledge that this test and this test are the most sensitive and have the best negative predictive value. In other words, urine cortisol, when it's very high, of course, is helpful, but many patients with Cushing's syndrome have normal urine cortisols. In fact, I had this discussion with an endocrinologist in Chicago last week, and he said, and I told him, I think urine cortisol is kind of like urine glucose. You know, I'm old enough to remember when urine glucose was the barometer of whether people had good blood sugar control. If they had glucosuria, probably not so good. I don't think that would be adopted anymore. And the urine cortisol is sort of the same way. It's not a very sensitive test. When it's very high, it's helpful, but when it's normal, it may not be. These two tests are helpful. And if they're both normal, the diagnosis of neoplastic hypercortisolism has virtually been excluded. Abnormal results certainly require the expertise of an experienced endocrinologist. But it was very gratifying to have this included in the 2008 guidelines. And what's interesting, and Hershel will probably mention it, there's just been another study from Europe, which validated these guidelines and said, and there was some question, should they be rewritten? But I think most people say that even though it's 14, 15 years later, they're still very reliable. So Hershel, you want to go ahead and take over?
Yeah, so when Tavi told us about this, I thought, well, wouldn't it be interesting to see just publications? And this is just late night salivary cortisol for Cushing's diagnosis, not stress or anything else. And before we published this paper in 1998, altogether from 1997 back to 1960, there were basically 8 papers. And nobody was doing it. Nobody was doing it in reference labs, and nobody was doing it in routine clinical practice. Then our paper, obviously it increased. But the thing that really made the difference was Jay insisting that it be in the guidelines. And that speaks to what Tavi spoke about in the very beginning, is that guidelines, whether they're correct or not, are very influential. You got a bunch of smart people in a room saying, this is what I think you should do. Most people pay attention. Some people ignore it, but most people pay attention. Now, I can't, we don't have a control group here, so I can't tell you whether that would have happened anyway, but I suspect that this was due to this increase in publications was due to the guidelines. Next slide, Jay. So then I thought maybe somebody might be interested in this. It's probably only people, lab rats like me, that care about it. But as I told you, we modified a serum cortisol assay for RIA. Then, because it became so popular, a company, Salametrics, which by the way makes assays for many, many analytes in saliva, not just cortisol. It's a great company. It's run by scientists, and that's why they're so good. They developed an enzyme immunoassay that doesn't require radioactivity. It's really easy to run. And they got it FDA cleared, which, as you know, for billing purposes is really, really critical. But then the English group suggested, well, if we measure cortisol and cortisone, now I'm not going to go into a 15-minute discussion of the biochemistry of cortisol metabolism, but it turns out that cortisol, most of the cortisol that gets into the salivary gland is actually converted to its inactive metabolite cortisone. So cortisone is 8 to 10 times higher, therefore easier to measure, therefore more precise. So we did a study where we had to use mass spectrometry, obviously, to measure cortisol and cortisone. We didn't find it much of an improvement. Others have. It's not that important right now. But the key for this study was that it turns out that making people stay up till 11 o'clock, which is I've learned in Milwaukee is hard to do. My bedtime's at 8, my bedtime's at 9, very few of our subjects stay up till 11. And some of them were going to bed at 8, setting their alarm clock and getting up at 11, which is obviously ridiculous. That talk about stressful. So we just did a quick study to see, and it turns out that a normal bedtime in a normal day is actually better. So now, in fact, Bev Biller just told me recently that she tells her patients, yeah, just do it at your bedtime. You don't have to stay up till 11 o'clock, but that's just kind of practical experience. So I don't know if anybody really cares about assay methodology, but it turns out that this enzyme immunoassay is just fine. So if you're interested in doing this, it's blindingly easy to do. I could do it in my basement with a plate reader. So next slide. And then this study was just published in 2022, and it's very hard to see, so don't worry about it. But it basically just confirmed that late night salivary cortisol, these are called ROCs, receiver operator curves, or late night cortisone, either one performs extremely well and better than all the other tests, and significantly better than urine-free cortisol, which is just confirming Jay's point. So Jay, why don't you take it over for the next
I
slide.
think one of the other things one of the criticisms of this test, legitimate criticisms, is the lack of specificity. And let me explain that. What I mean is that there are a lot of false positive, well, they call them false positive elevations. And my reaction to that is, well, they're not really false positives. The patient did have a high cortisol level at bedtime. It's just not due to a neoplastic hypercortisolism. So that, and I say, if you haven't had an elevated late night salivary cortisol in your life, you've had a very boring existence. I mean, I really feel sorry for you, because really, come on. For example, when we did our original study in 1998, and other people have noticed this, that one of our control groups was a group of nurses who were watching the Packers play the Bears on I don't know if it was a Thursday night or a Sunday night, doesn't matter.
It was Sunday.
It was a Sunday night game. I think the Packers lost. Maybe this may have contributed. And some of them had elevations of late night salivary cortisol. No kidding. Now, alcohol may have been involved in that, but the point is that it's of course there are going to be false positives. So it's not uncommon, and this study really showed that there's discordance. That sometimes somebody one night will be, upper limit normal is about 3 nanomolar, might be 4 nanomolar, but the next night they're 1.3 nanomolar. So I mean, it's not unusual. So sustained elevations certainly merit investigation, but there are people who have elevated levels who clearly don't have serious neoplastic hypercortisolism. But it's a simple test, can be repeated, and it's easy for patients to perform. Now, one of the other valuable things we've learned in the last 15 years is not only is it sensitive in diagnosing Cushing's, it's very sensitive in diagnosing post-op recurrences. And this may be where it's most widely used, is in patients who in remission from Cushing's disease, and probably somewhere between 10 and 20% may recur within the first, decade after surgery. That late night salivary cortisol elevations precede elevations of urine cortisol and may even precede abnormal dexamethasone suppression testing. And this is where it's become very valuable. And this is just one study which showed that, and there have been many others that have confirmed this. And in fact, and I can just tell you this anecdotally in my practice, because I see so many of these patients, that this elevation may be sustained for quite a while before patients even have any clinical manifestations. They don't even have any clinical signs and symptoms of Cushing's, but their late night salivary cortisol levels are a bit elevated. And these are two other of our I would say young junior faculty. These guys are already in their 40s, they're getting old, but Brad and Ty Carroll and Brad Jaworski, who I've had the pleasure to work with, did a study kind of confirming this late night salivary cortisol thing. We looked back at our clinic records over a period of about 5 or 6 years, and we had 112 patients with Cushing's disease who had undergone primary therapy. Now, 47 had been had insufficient data, were lost to follow-up. A lot of these patients were referred from other centers, and we didn't have any follow-up on them. But 65, we had full data, 15 had persistent disease, and 50 had an initial remission. And we had 15 patients out of this 50 that had a recurrence after initial remission and had some other therapy, pituitary surgery, adrenalectomy, pharmacotherapy, whatever. And out of these 15, only 3 had elevated urine cortisols and 12 had normal urine cortisols. So again, this just illustrates the insensitivity of urine cortisol, all normal in this group of patients, all of whom had significant clinical improvement with medical or surgical therapy. 9 patients, only 9 out of the 12 had abnormal DEX depression tests, but as expected, all of them had elevations of late night salivary cortisol. So not only did this pick up early recurrence, but also these are the patients who all benefited from some type of therapy. Again, just validating this whole concept of late night salivary cortisol as a sensitive marker of ACTH dependent hypercortisolism. So Hershel, you want to just talk about this?
So Jay and I were part of this humongous effort. It was like D-Day, organized
during the pandemic.
During the pandemic, yeah, it was like Zoom calls with more people on it than I've ever had seen. Maria Flesario and Bev Biller spearheaded this for the Pituitary Society, where they basically just got a whole bunch of people together. And Jay, why don't you just jump to the next slide, because you can see how many people were involved with this. It was a whole lot of people. I can't think of anybody that wasn't involved, to be honest with you. And it was published a couple of years ago as a guidelines update in 2021. It was published in Lancet Diabetes Endocrinology. And I looked the other day, it's already got over 100, maybe over 200 citations. I lost count. Next slide, Jay. And it was featured, late night salivary cortisol is kind of part of the zeitgeist now. I guess that's really the bottom line here. It's used for diagnosis. You can do it multiple times. The patient doesn't have to leave their house. They just, well, before the pandemic, we used the mail. I'm not sure how reliable the mail is now. You can do it to confirm if one of the other tests. And most importantly, as Jay, now there's a way to follow these patients, which was absent up until recently. And it's a horror. These patients, if you talk to them, I'm not a physician, but I'm part of the group of patients. And these people are the most grateful people I've ever met for finding this diagnosis after seeing 6, 7, 8, 9, 10 doctors who all told them they were either crazy or they should go on a diet. It's very depressing, actually, for me as a non-physician. You guys are probably all used to that, being experts in your field. But now that there's a way to follow people, and there's a simple way to diagnose it, there's really no reason not to do it. So, but this was really gratifying, being on this, being part of this update, and listening to really people that see these patients every day talk about how they use salivary cortisol. For me as a non-clinician, it was very gratifying. So Jay, why don't you jump to the last slide and you take it back.
So I think this story really starts with a collaboration, actually a friendship that I met with Hershel when I used to go over to Mary Dahlman's lab at UCSF, and because they were really doing sort of basic research and physiological research in the HPA axis. And that's where I met Hershel. And so we were sort of interested in the same thing. And I can remember the Endocrine Society meetings were in San Francisco in 1982. And I had just gotten to Milwaukee. And I don't even think I'd started working yet. I think it was sort of been in June, so I hadn't even started yet. But one of the things they promised me is I could hire a PhD to help with run the lab. So, I run into Hershel at the meeting, of course, and I tell him about this position. I said, now, why would this kid from New York who's lived in San Francisco doing a postdoc at it want to come to Milwaukee? I mean, it just doesn't make any sense. But when I mentioned the job to him, he said, yeah, I'll interview. And so he came out, and for reasons I still don't understand, he took that job. I don't know. I don't think he regrets it, but I have no idea why he made that decision. But I'm awfully glad he did, because he's been a great friend and a collaborator for a long time. So I think this all started out with the credibility of what we had done. I mean, I think you just can't come up with some idea if you don't have some credibility. And fortunately, we had some. We had compelling data, which was confirmed by many others, both in the clinical arena, meta-analysis, and everything else. And now it's been included in all the guidelines for the diagnosis of Cushing's, and I think has worldwide acceptance. But it's been a great pleasure and a joy to. If you've ever worked with Hershel, you understand. I mean, he's. There's only one Hershel, and he's been a great colleague for a long time, and I love the guy to death. So.
Thank you.
Yeah.
I think in a way, it's related to the credibility of the investigators, and you touched it on another slide. It's also, how do you manage the situation of being ahead of your times? Because you can come up with amazing research, amazing discovery, but it takes another 20 years for people to admit it, recognize it, or even consider it, right?
Yeah, it is sort of interesting, because I was on the bus at the end of the study, going from the hotel to McCormick Place, and Rob Wormers, who is head of endocrinology at Mayo Clinic, was sitting, and we just started, and of course I know Rob, he's a calcium guy. And he said, we were talking about publications and clinical research. And he said, boy, it must have been hard for you to publish all that stuff back then. Nobody, I mean, it was like so out there. And I said, yeah, I said, I don't really remember, you always, we've all sent in manuscripts and it's been rejected. I mean, come on, who has that thing? That's part of the game. I mean, you just keep, you get constructive criticism, sometimes not so constructive, and you modify things, you maybe do other experiments, it improves. I mean, that's one of the nice things about the peer review process. I think it really genuinely improves science. I mean, there's no question that's, and it's an amazing, it's actually kind of amazing because it's done at no cost. I mean, we all review papers. It's not like somebody's paying us. I mean, what other industry? I can't think of one industry that would do that. I mean, if you have a contract, you have to have lawyers. Well, they're not working for free to review the contract. It's, $1,000 an hour, or whatever they charge. I mean, but the scientific community presents data, it's peer reviewed, and the reviewers get no compensation. But it improves the quality of what we do. And I think, so there were some hurdles, and like this experience at the university. And I had a lot of, even with late night salivary cortisol, I can remember, even though I really thought this was working in the clinic, I remember, boy, could I be wrong? You always have this doubt. I mean, there's always some doubt. Maybe I'm wrong. Maybe this isn't, maybe there was bias in the selection of patients. I mean, you have to have some doubt, and I had doubts. But then when other people started publishing and validating what we had seen, then it became, I got, more and more confident. And certainly by the time we sat down to do the guidelines, I was very confident that this was a valuable resource and tool for the diagnosis of Cushing's. And fortunately, we got it in the guidelines. And I think that was a key step, and it's what worldwide acceptance.
Other questions or comments?
So I'm an endocrinologist too, and Adriana Akimescu, for those who can hear me. I hope you can hear me. So Cushing's syndrome is the hardest condition to diagnose in endocrinology and probably beyond endocrinology, because cortisol is a stress response hormone. And because elevation of cortisol, whether it's acute or chronic, happens in other situations that are non-tumoral. So I think this late night salivary cortisol assay really changed everything for those of us who were practicing endocrinology and were still, swimming in these muddy waters and not really knowing what to tell our patients, whether to have their glands explored by a neurosurgeon, even though even the MRI didn't show anything, or just wait until more comorbidities occur. So it has been a great game changer. I remember in my initial days in medical school and right afterwards in Bucharest, we were admitting everyone pretty much in the same way as NIH may still do this, right? So everybody with suspicion of Cushing's disease, Cushing's syndrome was admitted, and all the tests were done, including midnight serum cortisol. So using physiology, pathophysiology, and the power of assays just brought us to where we are today in a much better place. But still, I think there is just so much to do with cortisol and health and disease in general. We understand some of it, but not all. But yeah.
Well, thanks, Adrienne. I mean, I think, it's been a very interesting journey. Cushing's syndrome, I got interested obviously a long time ago. That's why I went to UCSF, because that was the center of Cushing's disease surgery in the late 1970s. I think most endocrinologists acknowledge that it is the most challenging problem they have to deal with, primarily because, particularly now that we recognize these milder forms that people may have with just, diabetes, hypertension, obesity, polycystic ovary syndrome, or whatever, or osteoporosis, that more screening is being done, so more diagnostic testing is being done. And I think this is rewarding on the one hand. On the other hand, it does, and one of the things that we're actually studying more now is not these non-neoplastic forms of hypercortisolism, like I mentioned, chronic kidney disease stage 5, or patients on hemodialysis. Almost all of them have hypercortisolism. And Hershel, I guess I mentioned earlier, has done I really think the best clinical study on that. But patients with alcohol-induced Cushing's, we just reported a big series that we had, the largest series ever reported, that just got published a few weeks ago. So a couple weeks ago, actually. So it's been a fun 40 years. That's kind of and this is, it's nice to go to meetings and have people acknowledge that, I think some of the younger endocrinologists, they say, oh, you're Dr. Findling. Oh, you're still alive? You're not dead yet? There's no way I can still be alive.
You should answer them that you only have left to solve the problem of adrenal insufficiency of the critically ill. That is done.
But I really appreciate, I think Hershel and I really generally appreciate, Tavi, you inviting us to do this and giving us the opportunity to tell this story with this, because I think it's a good one. And my friend Hershel and I have enjoyed the entire experience.
Are there any questions in the chat there?
Oh, I'm sorry.
Zoom, you have to unshare, we'll see some people.
Yeah.
too.
Yep. We can just stop sharing.
And until you do that, I want to tell you how I learned about when you collect the saliva. One of my patients, back when I was practicing in Atlanta, told me, of course I did it at
Absolutely.
11 p.m. or close to midnight. I remember exactly where I was when I did that, when I used the kit.
Yeah.
Said, where were you? At an Elton John concert in the park. Said, oh, you're gonna have to repeat this.
That's our time series reports.
Elton John gives a good concert. I don't know if you've ever, if you haven't, of course, I guess he's done touring now, but I've seen him about 2 or 3 times. He's really good. I mean, he
So-
gives a good show.
So following up on Adriana's point, which is even equally funny, I won't say the name, but there used to be an endocrinologist in town that would send the patients to the emergency room at midnight to get their blood drawn for their midnight salivary cortisol, and was
Midnight
always
serum.
shocked, serum cortisol, sorry, and was always shocked that they were always elevated. Meanwhile, there were gunshots, being, patients with knives sticking out of their head coming through the ER, noise and screaming and yelling and blood on the floor. And he was surprised that cortisol was elevated. And it just killed me. He read it in the paper. He said, oh, midnight, I can get that done. And he had to send the patients to the emergency room to do it. One of my all-time favorites. That was many, many years ago. But you're right, Adriana. I mean, it requires knowledge of the subtleties of the HPA axis is not widespread. And I helped some kids at Carthage College do a research project once, and they brought me their saliva samples. I said, when were they drawn? When were they taken? I don't know. They had no idea. I said, what do you mean you have no idea? Well, it's sometime between when they woke up and when they went to bed. I said, well, let's throw all this away and start all over again. So, I mean, understanding your system, the basic physiology, biochemistry of your system. And I have to say, I'm not just saying this because there are endocrinologists in the room, but of the many different and medical doctors that I've worked with, endocrinologists really do know physiology. And that, as Jay will, tells me all the time, is the key to a good diagnostic endocrinologist. If you understand the basic physiology of what you're studying, then the rest kind of falls into place. But yeah, so I also had a friend who was a patient in Michigan who was pregnant, and her doctor told her she had Cushing's, and they had scheduled pituitary surgery for her based on her blood cortisols, which Dr. Findling and Adriana can tell you is elevated because their CBG levels are elevated. And then I sent her some salivas. They were all completely normal. And this poor young woman was, while she was pregnant, was going to have her pituitary operated on. So, I mean, it's, this is just all about education and communication. And I guess that's the part of Tavi's presentation that I want to emphasize, is that it's one thing to publish a paper. It's another thing to communicate it. And Jay is really, really good at that, much better than I am, about being out there, willing to take, the bullets on behalf of your idea. And I think Tavi mentioned that too, saying, no, I know I'm right, I'm going to keep pushing ahead. That takes a lot of guts. Many of us don't have it. I know I don't.
So I guess Harvard University, did they offer you any?
University of Connecticut?
Oh,
Okay.
University of
Connecticut, yeah,
Connecticut.
that was a very deflate. I mean, I remember how, I was a fellow at UCSF. I mean, you go to a place, you give a presentation, and they just, like, you're nuts. I'm paraphrasing. I mean, they weren't, but they just said, oh, this is crazy. I mean, you can do high dose. Why would you want to do this procedure? And so I think it's the same. And I never got, I wasn't offered a position, obviously, but it was very deflating. I mean, I thought, gee, maybe they're, I thought maybe I'll never get a job. My research is so bad I won't get a job, but fortunately the medical college hired me. So I had and then they hired me with the idea that I could get a PhD. So that was really turned out to be a great miracle. I met, Hershel took this job, and we've been doing this together for 40 years. Thanks, Hershel.
Well, thank you, Jay. And without belaboring this, the reason I came otherwise, in addition to Jay and I being friends, was I just couldn't see myself sitting in a lab playing with rats for the rest of my life. Now I still do that. I still do animal research, but there was something about it that I found very limiting. And the chance to do translational research. And of course, when we were at St. Luke's, I got to work with the cardiologist, the pulmonologist, because I'm basically a cardiopulmonary physiologist. And they also, the management there was a lot different than it is now without going into politics. But they were basically just they opened the books for us. What do you need? You have whatever you want. They had a lot of money. They didn't really care what we did and said, if you need anything, let us know. And you know, if I was going to give a message to an administrator, which is not what I normally do, you should always say, what can I do to help you succeed? And they did that there. What can I do? Mr. Howe, who's the president of the hospital, said to me, you come to me, I'll do anything I can to help you guys succeed. You don't hear that very much anymore. And it was a real revelation to me. It was hard at first because we were a little isolated, but then Jay recruited Joe Shaker and Steve McGill, and things kind of picked up.
So one of the interesting stories is that when Hershel came on board, he was a physiologist, and I wanted him to be in the Department of Physiology, become assistant professor and teach and so forth. So I call Alan Cowley, who was the head of physiology at the time. And I didn't know Alan. I mean, I'd never met him. And I said, here I have this young man who I've recruited from San Francisco, UCSF, sent him the, CV is whatever. I said he would like to participate in your division, teach, and get an academic appointment. Well, Alan kind of, because he didn't know me. I mean, I had no reference point, and he said, well, I'll consider it. And I think Hershel probably knows, you must have interviewed with him, and I think he and Hershel hit it off very well, and he embraced Hershel. And I mean, Hershel's probably taught more medical students. I mean, how many you taught the dean, for crying out loud?
The dean, Jose Franco, they were in the same class. I remember Jose used to wear Yankees stuff. Everybody would throw things at him. But they were in the same class, along with John Lehrman, the chair of psychiatry. I counted up, Jay, 10,000 medical students I've taught. And so if you get really bad medical care, you know who to blame, okay? But I added it up recently, and it was 10,000. It's hard to believe it's gone by so fast. But I have to say, Alan Cowley, I mean, he makes you earn it in the old ad, he doesn't, I mean, I had to really work to get into that group. And I had to get my own grants, but he was great. And he was like, if you show performance, he'll give you anything you want. If you piss him off, you might as well pack it up and leave. So, you got to learn the personalities that you work with. But Alan, as you all know, is a world-class physiologist. But he was very careful about who he brought into his group. And that's actually a very good lesson. Mary Dahlman once said to us, never bring anybody into your group that you don't like on a personal level. It's a mistake. And I only made that mistake once, and I never make it again. It's such a great thing to think about. When you're recruiting somebody, first you have to like them as a person. And Mary used to go on and on about that. And I think that's great advice.
I think the other angle that is interesting is we were talking during the last month's presentation about the dyad between the skilled craftsman's model, where the master clinician, it kind of provides that individual image of an expert and how that can shape practice guidelines versus, the dyad, or we have to standardize, we have to have the same type of approach in everybody.
Right.
And you kind of touched on a couple of angles. One is, skilled craftsmanship in education and in research. And the second part is how that actually can influence guidelines creation, both in a positive and in a negative way sometimes.
Yes.
And how evidence generation and evidence-based or evidence-informed guidelines can actually take the wrong turn or be in the right direction after a decade or more of investigation, right?
Yeah. No, Yeah, that's true. I mean, I'm very happy that, I mean, I'll be honest with you, until Tabby called us, I'd never even heard of implementation science. That was a term that was foreign to me, or I've learned obviously a lot about it now. And it makes some sense that, and as I think we didn't, I mean, it wasn't part of our equation, of course. We just did what seemed right, and it evolved, and fortunately in our direction. But I think this is an important concept. I mean, that once discovery is made, either a basic science or, now pharmaceutical companies have a much easier time getting from, they come up with a GLP-1 agonist, or they come up with some new thing, and they because they have the resources to do that, and they have a motivation called profit, of course, and they can get things rolling quickly, albeit at spending a lot of money to do so, to get things from the basic science arena into clinical practice. And I think it's a little different model than we have in basic science and academic center.
Any other questions or comments?
I don't, any other questions? I don't, none in the chat.
Well, thank you so much, both of you and our entire audience. This has been great. Next month, we're going to have a nice talk from another outside speaker, Andrew Downward, who's going to be presenting about organizational maturity levels and how those apply to implementation. So thank you, everybody. Have a nice evening. Bye-bye.
Thank you.